Hi, everyone. I'm Dr. Sarita Rao. I'm an associate professor at the University of Connecticut School of Medicine with the Department of Psychiatry. And I'm an addiction psychiatrist, and I'm also the program director for the psychiatry residency training program. So today I will be talking to you a little bit about the pharmacotherapy management issues for women with opioid use disorders. And this includes pregnant women, so pregnant mothers with opioid use disorders. For women with opioid use disorders, there are a lot of issues, like women with any kind of addiction, that sets them apart a little bit from the men with the addiction. So one big issue is pregnancy and childbearing. So when you have a pregnant mother that's using, it's not just the mother, but the baby you have to think about. Also, women with young children. So sometimes women will stay out of treatment because they're afraid to come in, because they're afraid that if they come in when they're pregnant, other children that they have might be taken away from them by social services, or they're worried that the baby that they're pregnant with will be taken away when they deliver. So it's always this push-pull between trying to help them and trying to also make sure that their existing children are safe. So there are a lot of options for these pregnant drug-using mothers, particularly in Connecticut. There are some residential programs, which are either very short-term, like 28 days, or long-term, 3 to 6 months, where a pregnant woman with opioid use disorder can live, get group therapy, individual therapy, family therapy, case management, medications, maybe see a psychiatrist if they have any dual diagnosis issues. And at least 2 of these programs in Connecticut allow a pregnant mother to keep 2 toddlers with her that are under the age of 5 in the program. So this allows her to get treatment without being separated from the children. In addition, women can go to a day treatment program where they go for several hours a day, 5 days a week, or they go for a few hours, 3 days a week. And this allows them to take care of their families and also maybe work part-time if they're able to while doing all of this. And so it's very important to assess for comorbid psychiatric conditions. A very large percentage of women with substance use disorders had childhood sexual abuse or further trauma as adults, as they often exchange sex for drugs. It's a relatively common way for them to fund their drug habit. But in that process, they can get further traumatized, even though they seem like they're doing it voluntarily. Nobody really voluntarily does such a thing, and it's more driven by their desperation to get drugs. So they need to be assessed for any post-traumatic stress disorder, depression, anxiety, domestic violence. Outpatient treatment is another option, which is a little bit less intense than all of this. If you get a pregnant woman who is addicted to opiates, heroin, OxyContin, prescribed, not prescribed, you don't want to refer that pregnant mother to detoxification. And the reason is that detoxification from opiates, even medically supervised detoxification, does increase the risk for miscarriage, and you don't want to take that risk of losing the baby. The second thing is that even when these women are detoxified during pregnancy, a lot of times they will relapse again. And so then they're going through these cycles of using and coming off. The baby's going through cycles, and they drop out of prenatal care. They don't take their vitamins. Their nutrition is poor, and they just have the erratic, unsafe lifestyle of an active drug user. An increasing problem in our country, in the United States, as we go through this opioid epidemic, which is not America's first opioid epidemic. It's like the 3rd or 4th. And you can search for the history and read all about it. We never seem to learn from the lessons of history, and we sort of repeat it. But now that we're going through yet another opioid epidemic fueled by prescription opioids and street opioids, a lot of toddlers and babies are ending up overdosing on opioids. Either illicit opioids that their parents bring home and just leave around because they're not thinking clearly, because they're under the influence of drugs or they're seeking drugs, or even sometimes their own medications, their agonist maintenance therapies, methadone or buprenorphine. When they bring them home, they have to put them away safely, because if their toddler or their young child or their baby puts it into their mouth, they could die very easily from a small dose. So here on the slide, I've put in an article actually from the lay literature from the New York Times, which is sad but interesting about this topic. So untreated opioid addiction during pregnancy can have really devastating effects on both the mother and the baby. And these fluctuating levels of opiates, if the mother's out there on the street, sometimes getting opiates, sometimes not getting them, can have bad effects on the fetus as well, and expose the baby to repeated periods of withdrawal, which can then harm the placental function. So this is just a slide. I'll let you read it on your own time, and you can also read the article that's referenced at the bottom, is of all of the terrible things that can happen when there's ongoing heroin or oral opioid use in a pregnant mother. It's everything from spontaneous abortion to intrauterine death. And so this patient is always considered a medical emergency. And if there's a methadone maintenance program in that area, they usually jump the waiting list and get enrolled right away. So why put a pregnant woman on methadone maintenance or buprenorphine maintenance? What are the advantages? Maintenance treatment helps the woman to stop using illicit substances, get a more stable life, stop exchanging sex for drugs, stop committing crimes, stop going through the ups and downs, the highs and withdrawals. It allows them to get into prenatal care for a high-risk pregnancy if need be, and it allows them to get better nutrition, a stable place to live, and take their prenatal vitamins, and get some parenting education during her pregnancy. Here there are some more risks in this slide of opioid misuse during pregnancy. And some of it is just things associated with a drug-using lifestyle, exposure to violence, possibly incarceration. If the mother gets incarcerated and she has another child that's a young child, that child, if there's no other person to take care of it, if they don't have a stable father or stable grandparents, aunts and uncles, they might go into foster care. And then malnutrition and risk of the mother getting infected with HIV, Hep C, Hep B, all of which will have then effects on the baby. So, do we test the mother and baby for the presence of drugs at delivery? In Connecticut now, it is not legal to test a mother who has delivered a baby in the hospital without her permission. So if you want to get a urine drug screen from the mother to see if she's using drugs, after she's delivered the baby in the hospital, you have to get her permission. However, you don't need permission to test the baby's meconium, which is the baby's poop. So, and that can carry the evidence of the mom's drug use for quite a long time. So, however, sometimes mothers and babies get discharged from hospitals. The baby might take a few days to poop, and by the time the results of the meconium tox screen come back, it might be several days. Now the mother's out in the community, and somebody has to be sent to kind of track her down and see if it's safe for her to stay with the baby. Normally in hospitals, just the fact that the mother's drug screen or the baby's meconium has come out positive for anything, whether it is opiates, whether it is cocaine, is not always a reason that we refer the mother and the baby to Department of Children and Families. Sometimes the hospital social worker and the physicians will do that, but sometimes the patient will agree to go into treatment, and maybe there's some other family member that is looking after the baby, and so at that point that referral may or may not be made. It's a judgment call on the part of the treatment team. They have to look at what's safest potentially for the newborn infant and what will help the mother get into treatment. This is a slide on neonatal abstinence syndrome, which is an important issue for mothers with opioid dependence. So if a pregnant woman is either using illicit opioids or is now stabilized and is now placed on methadone maintenance or buprenorphine maintenance, both of which are opioid agonist medications, either way, the baby is still born physically dependent on opiates and has to go through withdrawal. And this withdrawal is called neonatal abstinence syndrome. It is unfortunately pretty distressing for the baby, and has to be treated so that the baby can get relief and safely come off the opiate. But it is not harmful in the long run for the baby. So once the mother is stabilized on methadone or buprenorphine, they typically have good outcomes in terms of the babies that are born to them because of all the factors we talked about before. So neonatal abstinence syndrome is characterized by signs and symptoms of central nervous system hyperirritability. The baby often has a high-pitched cry. There may be symptoms, gastrointestinal symptoms like diarrhea or vomiting, respiratory system dysfunction, all of which in a newborn infant can be far more risky than it is in an adult patient. So typically these babies are kept in the hospital in the neonatal ICU, and they are managed there until the pediatricians feel that they are ready to go home. And typically they're often treated with an oral opiate, morphine or methadone, given based on their body weight and size, and sometimes less frequently like phenobarbital or a benzodiazepine, along with things like swaddling and holding them and monitoring them to see how things are going. So basically the goal is to mitigate the symptoms as much as possible while still keeping the baby safe and just trying to make it easier for that baby to come off the opiates. The next few slides are about the mother study, which was a large study done in the United States. It was done a few years ago. It's a very important study. It basically compared how mothers, pregnant mothers and their babies do on methadone maintenance treatment or buprenorphine maintenance treatment. When the study was done, it was the early years of pregnant women being maintained on buprenorphine. So I will let you read through this slide on your own. It is a lot of information. This is just a description of the study. So there was 1,074 patients, and out of that, 175 were randomized to either buprenorphine or methadone. And then in the boxes below, you can see 58 of the buprenorphine patients completed the study. 73 of the methadone patients completed the study. The mothers on buprenorphine, one of the reasons why they sometimes did not do as well was that because it's a partial agonist, it did not treat the drug hunger quite as well as the methadone did. And so sometimes, even though the baby is going to have an easier time after birth with the neonatal abstinence syndrome if the mother is treated with a partial agonist, but sometimes it's might be important to switch the mother to a full agonist like methadone because the mother has to be retained in treatment. So if the mother's drug hunger is not treated and she's still craving opiates and goes out there, drops out of treatment and uses, that's not good for the baby either. So you have to balance out all these things. There's no perfect answer. This next slide is important because it really shows you the mean neonatal morphine dose and the length of the neonatal hospital stay and the duration of treatment for the neonatal abstinence syndrome for the baby. So the orange bars are methadone and the blue bars are buprenorphine. As you can see, if you look at the total dose of morphine that these babies got, the number of days they stayed in the hospital, the mean number of days, and the mean duration that they needed the neonatal abstinence syndrome treatment, there's a big difference. So the buprenorphine babies got a lot less morphine, they got less, a shorter length of the neonatal abstinence syndrome treatment, and they had a shorter stay in the hospital. So, however, I would caution you, somebody seeing these slides would be like, wait, why don't we just put everybody on buprenorphine that's pregnant? Well, because of what I said earlier, if the mother is really not doing well on the buprenorphine as a partial agonist and still has a lot of craving for opiates, then it's important to allow her to say that and to transition her to methadone without letting her feel a lot of guilt or anything like that, and just reassure her that what's best for her and for the baby is for her to be stable, not use any street drugs, any alcohol, try to stop smoking cigarettes, just cut everything out, good nutrition, prenatal care, and that's going to result in a good outcome. So this is the summary slide. There's significant public health and medical costs associated with treatment of neonates, which are newborn babies, exposed to opiates, which has gone up with the opioid epidemic. So in 2009, it was estimated to be $70.6 million. And anywhere between $70.6 to $112.6 million. Plus, there's the human cost of these babies who need to be given a good, healthy running start, even before they're born, so to speak, and certainly as soon as they're born. So clinical management of the pregnant women with opioid dependence needs further research to evaluate what are the short and long-term outcomes for the mother and the child. But so far, in all these years, methadone has been a very established treatment for pregnant women with opioid use disorders, going back to the 70s, buprenorphine for the last many years, and the general consensus among addiction medicine specialists is that these are very safe treatments for a pregnant woman and for her baby, and the babies usually have good outcomes. Thank you.